The first question I have here is, it is, in your opinion, why do you think the rates of CP care, CP are increasing in term infants?
Thanks for that question. I think it's an interesting question. So in fact, it depends where you look at the data. So in countries like in Scandinavia and in Australia and in Canada, in fact, the rates of cerebral palsy are decreasing in term-born babies. However, they are often increasing, we suspect, in low-income settings, and that's for a number of reasons. So there has been a detailed effort by the World Health Organization and many others contributing to the Millennium Development Goals to protect the health of mothers and babies, and this has led to better survival amongst infants, but it has also led to survival with disability. So this is a trend that people are observing with their eyes. There aren't strong data sets, although they're in the process of being built in places like Sri Lanka and Bangladesh are now opening registers. So we will have more information soon, but the rate is actually going down in high-income countries.
Good, thanks. Then the second one is the role of antenatal steroids as a neuroprotective agent. Could you please elaborate to the possible mechanism of action?
This is a great question, and it's one that should have gone to clinical trial but never did. It's the standard of care now, and so I don't think we're ever really fully going to know the answer to this. We believe it's a neuroprotectant because it protects from excessive oxidation in the brain during an injury. However, the real mechanism and the efficacy data is not well understood. It was so quickly adopted into clinical practice that data doesn't really exist. Although you could ask that question to Professor Chevelle again, and he might have a more detailed perspective for you. But antioxidant mechanism is the hypothesis.
I think you may reflect on that later on, Michael, in the lecture.
Can you repeat the specific question, please?
The question is about the mechanism of antenatal steroids as a neuroprotective agent.
There's all sorts of hypotheses, but once again, the definitive answer is we don't know. There's all sorts of postulated individual mechanisms, but one does not know what specific mechanism is active in this particular situation.
Good. So the next question is as follows. We run a multidisciplinary clinic for children with visual impairment, and 70% of the children have cerebral palsy and visual impairment. Please, would you comment on the evidence or recommendation of the effect of visual stimulation in children with cerebral visual impairment in view of neuroplasticity?
This is an excellent question, and I really hope the person that asked this question would like to do a PhD on this topic at some point. It's a very under-researched topic. So I think up until very recently, cerebral visual impairment in children with cerebral palsy has been very under-recognised. We don't have good population data on the exact rate, although we think the rates are much higher than what is reported in literature. As for intervention, there are two main overarching approaches, one developed by Professor Roman Lansky in the United States and another at the Smile Lab in Italy. And we're about to go to clinical trial actually in 2 months' time, testing the efficacy of the Italian model, which is based on a neuroplasticity model. So they actually look at the brain scan, look at the areas of injury and location, and choose a visual stimulation program based on the pattern of brain injury and the child's functional vision impairment. It's never been tested in clinical trials, so we'll have those answers relatively soon, but there is only one other study currently underway with children with cerebral visual impairment in Cincinnati, and it's using a web-based training program. But otherwise, if you were to do a structured literature search, you won't actually find any papers. So we acknowledge it's a problem, but we don't have any evidence about intervention. We do know that vision is highly neuroplastic in the first 2 years of life, and we do think this needs to be an early intervention, and certainly these children's vision can improve in the first 2 years. So that's why this is a research focus that has been identified by parents, and we're excited these 2 trials are underway, and I think more results will be available soon.
Good. So the next question I have here, I think it boils down to the fact that we don't always have MRIs available in the neonatal period. Is there an optimal timing for the MRI then in the early diagnosis of cerebral palsy?
That's a terrific question. So our clinical practice guideline published in JAMA has that information in it, so you could go back and have a look at that. It depends on when you're born. So if you're born preterm, the best time is at term equivalent age to take an MRI. If you're born on time but have a hypoxic event, then it depends on the centre that's doing the scanning, but it's often 5 to 7 days after the injury to allow the development of the injury to be showing up on diffusion. We've written up those parameters in the guidelines, so you could have a look at those. It's around term equivalent age, and the benefit of that time period as well for the infant is that they don't need a general anaesthetic. It can be a sleep scan at that point, and so they're much safer and more feasible to conduct.
Good. So the next question is, when referring for early intervention, which interventions do you suggest between the age of 3 to 12 months?
Sorry, can you just repeat that? I couldn't hear it on the line very well. Which intervention from 3 to 12 months? Is that the question?
Yeah, 3 to 12 months.
Yes. So we're just in the process of now developing an international clinical practice guideline that summarises all this data. So I can give you the high-level findings. If the goal is to improve the child's movement skills, the systematic review data that we generated showed that task-specific approaches that focus on contingency-based learning, and what I mean by that is that the child has an observable action from the toy and therefore repeats the response, and that is high intensity and is self-generated movements. They're the 4 key features that come out. So that those are typically motor learning-based interventions, goal-directed training, and functional training types of intervention. That's where the best evidence is currently for developing movement skills. For developing cognitive skills in infants with cerebral palsy, it's actually never been tested, but we assume developing cognitive skills follows the same patterns as other children. So the high-level data at meta-analysis suggests that reading, interactive reading, is one of the most important things we can do for cognition. Discovery-based learning, where the child has many opportunities to fail and experience success. And social interaction with parents, where there is an attachment-based intervention where the parent is reading the child's cues and offering responsive parenting. And those are the things that we know lead to the biggest cognitive improvements in all children, whether they're normal or have a disability. And so we assume the same applies in cerebral palsy, although they've not been tested. For language development, the best available evidence is quite low quality evidence, but suggests using a parent interaction program where you respond to the baby's cues, something like humming or a parent training approach. And if the child has a severe motor impairment that is likely to affect verbal speech long term, so for example with dyskinesia, if the baby's on a trajectory towards probably genus yes 4-5, then early use of switch-adapted toys for response-based communication so that you can stimulate receptive language can be incredibly important as well, although it's low-quality evidence. For sleep, in the early phase, obviously you want to investigate for any medical complications that could be interfering with sleep. And if there are none of those, then standard behavioural approaches after 9 months are appropriate, but before that, not really appropriate. They're sort of the main domains.
Good. So the next question is then, should we be giving EPO to our asphyxiated infants, erythropoietin?
Sorry, can you just repeat that? I couldn't quite hear it.
Should we be giving EPO, erythropoietin, to our asphyxiated infants?
That's a great question. It's still a clinical trial, the answer to that question. Erythropoietin has been shown to have a positive effect from a regenerative medicine point of view in preterm infants in a clinical trial conducted in the Netherlands. There is a French trial using EPO for babies with hypoxia that was stopped early for statistical reasons but had a promising trend. There is a phase 2 study by Yvonne Wu in San Francisco showing positive study results, and we particularly see in that study that there is a reduction in cerebellar brain injury after EPO, which suggests that it might be neuroprotective of some micro lesions, which could be neuroprotective for cognitive function in these children. Yvonne Wu is currently completing a large phase 3 trial. We're also completing one here in Australia and New Zealand with 300 children. So the evidence at this stage is promising pilot clinical trial data to suggest this is likely to work with a low adverse event profile, and the 2 definitive trials are currently underway, and within the next couple of years we'll know the answer to that question.
Thank you. So the next one is, should we be recommending stem cells for our CPs?
Sorry, can you repeat that one again? I couldn't quite catch it.
Should we be recommending stem cells for our CPs?
Great question. Should we recommend stem cells? I guess it's a complex question. Many parents are going to ask, should I have stem cells? There is promising pilot data that umbilical cord blood is certainly safe to use in cerebral palsy. There is now 3 clinical trials complete and another one underway, suggesting a dose parameter that is required to reach efficacy levels. So we do see small improvements in gross motor skills and potentially cognitive skills over and above rehab alone. It does need a larger trial, which has been completed at Duke University, although they use the cord available dose, if you like. So every cord has its own individual properties and no 2 cords are the same. And so it means for an infusion it's different doses for different children. So we do now know the threshold dose, and I think people will go on and repeat these studies. So it's not at the point where you could say it's we could say it's definitely safe. We could say there's preliminary efficacy of umbilical cord, and people are now working on expanded cord blood at high dose because we know the dose threshold now, and of course this is an intervention that people want as multiple treatments. Since it isn't a cure, it's a treatment effect. And so those studies are just currently being designed. As for other types of stem cells, at clinical trial, people are looking at mesenchymal stem cells as a anti-inflammatory mechanism in neonatal stroke, and that work we're yet to see what that does in neonatal stroke, but that's been investigated. That large animal studies are very promising. And then as for neural stem cells, there are 2 trials conducted in China. Both of them used a delivery route which the authors concluded was not effective because the cells could not cross the blood-brain barrier at high dose. So there have been other studies done in other neurologic disabilities such as Batten's disease and Pérez-Mérbacher disease in preparation for a cerebral palsy trial where they actually implanted the stem cells stereotactically into the brain in order to cross the blood-brain barrier and got a much bigger clinical result. So we're yet to see those trials repeated in cerebral palsy, but there is a few important stem cell groups around the world working towards those types of clinical trials. Another another type of cell being considered for cerebral palsy and is about to go to clinical trial is also amnion cells, which are a cell extracted from the placenta, which has some advantages over umbilical cord because you can expand the cells more quickly and you can use donor cells. You don't need to have your own cell bank. So I think my summary always to parents is it appears that we can make stem cells safe, but if you're being sold stem cells, then you should be incredibly cautious about that because there aren't proven interventions. You could look at joining some of the good clinical trials around. I think stem cells are probably here to stay, but they're not at the point where they're proven to work, but there's preliminary positive efficacy.
Good. So the next question is, what about NDT therapy in our gross motor function classification level 4 and 5? What therapy would you recommend in these patients or in dyskinetic CPs?
It's a great question. I think I'll start with probably the fine print, that NDT, being an umbrella term, means lots of different things to different clinicians. So no two NDT trained therapists necessarily practice the same way. So people might mean different things by that term. For some people, they have adopted contemporary motor learning approaches and that's 100% of what they do. Some people are truer to the original definition and would use some passive non-self-generated movement by the child, such as range of motion and facilitation and preparation for movement. So the systematic reviews are clearly suggesting that if the child, if the therapist doing all the work in terms of prepping the child for movement, facilitation, stretching and range of motion, there is no clinical gains in those children over and above no therapy. However, if the person that says they practice NDT happens to use a motor learning approach, then you are likely to get a result. So I think the important thing with children GMSTS 4 and 5 is to understand at what age you're treating them. So if they're younger than 3.5, that means they still have motor potential and should have access to motor learning and task-based performance motor learning strategies because they can respond. But if they're older than 3.5 and they've hit the 90% of their motor potential, as we know from the growth motor curve, then it's very important with those children that you switch from a motor learning approach to a compensation approach where you think about their inclusion as a person in society and what adaptations we can make around them to have them fully included. So the use of technology is incredibly important after 3.5 for those children, and identification if the parents are choosing goals for therapy that involve acquisition of motor skills, that we're very honest with them as clinicians about realistically whether those goals are achievable or not from a motor perspective. So I will sometimes hear clinicians saying, should the child have the right to practice walking at 6 years of age if they're GMSTS 5, just in case they learn it? Well, the data would suggest they're not going to. It's actually probably kinder to that child long term to get them a power wheelchair and make them fully included and have the experience of independent mobility via another mechanism. So I think it becomes important with those children that, A, we're evidence-based, we're realistic, we use compensation to promote inclusion and participation in the whole of society, but we also think long-term about their musculoskeletal history. So those children have the highest risk of secondary impairments such as contracture, scoliosis, hip dislocation, and many of those things can be lessened or prevented by good musculoskeletal management, early referral and monitoring by an orthopaedic surgeon. And that's very important because if those things are unmanaged, these children experience great amounts of pain and can also fall backwards a full GMSTS level. We know that thanks to great Canadian data. So it's very important that we also manage and prevent impairments in those children.
I think the next two comments actually ties up very nicely with this because one of the people in the audience says that 64 interventions are looked at in the review or the meta-analysis, and 22 are incorporated in the NDT approach, like the home programs and the goal-directed and the casting and post-op Botox rehab. And the opinion, your opinion just about that, but
yes, I think that's why I was saying before, the definition of NDT means different things to different people. So when we did that systematic review, we extracted clinical trials that existed in the literature and we used the authors' definitions within the papers. However, the clinical trials, there are 10 of them in cerebral palsy using NDT, where that's what the authors have said they've done. Only 2 of them show a benefit, 8 show no benefit over control. So, but they were using more passive, more traditional aspects of NDT. And you're right, many NDT practitioners also use many other contemporary approaches which were invented after the Bobars passed away, but they've become part of the NDT umbrella. So I think one of the most helpful publications was from the head of the Bobars Society last year from Britain that said, I just wonder if maybe the best way for us all to move forward is not so much to use the term, but actually to call interventions what they really are. By calling them an umbrella, it's very difficult to understand which interventions people are getting. So I tend to say to people, you know, imagine a scenario where the original telephone provider provided analogue phone services, and after a while a second competitor came up and they said, we offer digital. And then to be still in offering service to customers, the original provider said, oh, but we also offer digital. It's unclear then if you're the customer, are you getting a digital phone call or an analogue or a bit of both? And this is the challenge with the term NDT in the current era. It means lots of different things. I think it's much more helpful if we call something a home program, we call something casting, we call something motor training, or we call something stretching, so that we can all understand the evidence base. By clumping things together, it's hard to know exactly what people mean. So I'm not personally, I don't have an opinion or a preference. I'm a person that believes that all children should have evidence-based care, and I think by using the clinical trial data and the names of the interventions, it's easier to understand which pieces of an approach actually do work.
So NDT can actually be seen then as an approach constantly changing, and that it may have different components, and that one should actually look at the different components and then give a specific opinion on the specific component.
Yes, I hold the same opinion as that, because I think many methodologies change over time, and it's important to understand people are getting the most current and up-to-date services. And if we just call them what they are rather than putting them all inside the banner of one label, it's easier to understand that the child is getting up-to-date services. So I happen to hold the same opinion as the person that asked the question. I think it's clearer for families and it's clearer to policymakers and other clinicians if you use the component terms rather than the umbrella terms.
Good. So the next question is as follows. The brain pictures used or showed neuroplasticity with in children with I'm not sure what it, are those the pictures that you use, were they in children with cerebral palsy or without cerebral palsy regarding the neuroplasticity? And if it's not CP, is there research or evidence of neural growth in CP children?
That's a very, very good question. So inside of the slides, the juggling brain slides and the musician brain slides and the past specific training brain slides, they were all of normal human subjects without cerebral palsy. But we know that regardless of what type of brain injury you have, repair and neuroplasticity happens in the same way. So the same modelling happens in cerebral palsy. It just depends how much cell death has occurred, whether it's possible to reignite a new connection or whether it's possible for the brain to build a new connection around the glial scar, for example, or whether no connection is possible. So it just depends on the size and location of the injury. However, there is data in cerebral palsy, so there is some clinical trial work out of Italy and some clinical trial work out of Brisbane where they have shown increased tract development and tract length in response to training-based interventions. So these interventions used in these trials, we see these neuroplasticity gains on advanced neuroimaging techniques and using tractography and things like that when the child's had a training-based or learning-based intervention, not when they've had a passive intervention, because obviously it's activity-dependent plasticity. The child actually has to self-generate the movement and practice the movement at high intensity to see those types of changes on brain scan. But yes, we have seen them in a number of clinical trials, and we have 3 more clinical trials currently underway in Australia that is collecting neuroplasticity data. So again, we're going to have more of that soon. But most of the studies, have around 20-ish patients, but do show us, particularly the hemiplegia, that have the greatest motor potential, that neuroplasticity does occur.
Good. So the second one on this list is when showing videos of the active participation versus the passive participation, it is not accurate to compare a baby 3 to 6 months with a highly functional adolescent or adult. CP as a baby requires handling even if normal. Do you have comparisons of more similar ages or diagnoses to compare resistance or restraint therapy, NDT, or SI, sensory integration?
I don't have any more videos I could show you, but we could pull out the individual patients in clinical trials. So I have to say I disagree. No normal human needs preparation for movement. No normal human can walk or talk or write their name at birth. All of that happens from practice. And we think the same thing happens in cerebral palsy. Passive handling in the 8 clinical trials that have compared it to either no intervention or natural development have shown it doesn't improve motor skills at all. So I tend to park that aspect of NDT and just use motor training intervention. So perhaps we have a different opinion on that, but that's certainly what the clinical trial data suggests.
On the same list, it concerns the brushing techniques. There was some concern that it was not that it was done incorrectly, and therefore is it poor evidence? And then also the comment that it was not designed for CP kids, but also only in and forms also a very small portion of SI treatment, and therefore it may not be a fair representation of SI treatment and SI treatment sessions. Do you have any other evidence of sensory integration in CP, apart from the brushing?
Right. So some sensory integration trials try multiple different aspects of sensory integration, and some studies have just looked at the wheelbarrow brushing protocol in isolation. Either way, again, these trials have showed no benefit over control or no therapy. That there are other methodological challenges with these trials, but there are 7 meta-analyses that suggest the same thing. So it's complicated because people often feel very committed to that approach. However, the data just isn't there.
Good, thank you. And then there is a question from our mediation team, are CP cases being mediated in Australia?
I don't use the term mediated. What does that mean in a South African context? Can you help me?
It is used in the context of alternative dispute resolution before any litigation is then continued with.
Okay. Yes, right, I understand. That is a possible option for people to have mediation and discuss this before they look at full litigation investigations for causal paths for cerebral palsy. It's an option. In Australia, medical negligence as a cause of cerebral palsy is less than 1% of cases, although we do know law firms tend to pay out a little bit higher than that. I think obstetricians get an unfair rap often for more than 80% of cases of cerebral palsy, the cause is in utero. Is that certainly not on the obstetrician? So it's a complex area, but mediation is available for people to discuss, of course, the hurt and shock and pain they feel at the time of diagnosis and understanding their child has a disability and wondering if there is someone to blame or an opportunity for cost recovery to ensure best care for their child.
Thank you. There's another question coming up, and then if there's any other questions that's not been addressed from the audience, it's your last chance to bring your question on a piece of paper, and then I'll read it to Professor Novak. The question that I have at the moment is there any correlation between Wallerian degeneration of the corticospinal tract with GMFSC 1 to 4, and how does that influence neuronal function, plasticity, as well as the topography?
Wow, what an amazing question. I think you should ask Dr. Chevelle as well. But pre-Wallerian degeneration or Wallerian degeneration can be a causal or a brain lesion pattern that we describe as causal of a motor impairment being cerebral palsy. I don't think I am aware of a lot of data that tells us about the relationship between tract development and function in those children. I tend to think of the MRI as a little bit like a map that tells you the likelihood of functional damage, but then I tend to prefer to assess the child and see whether the functional limitations actually exist and put it together that way. But Professor Chevelle might be able to give a more intelligent answer than that.
Good. So we will ask Professor Chevelle the same question this afternoon on his session about medical management further, just as an add-on. So is there any other questions that one of you may have that you would like to ask Professor Novak? Well, Iona, thank you very much for your kind gesture. I think it's quite late there to join us on this question and answer session. We really appreciate it. One thing that I'm 100% sure of is that we are stimulating debate, we are stimulating discussion, and only through an active academic kind of discussion, we will be able to find a way and understand and get the best management for our patients and the best care that we can give them. Once again, thank you so much. I really appreciate all the effort you put into from your side there in Australia, and all of the best for you and your work. Thank you.
Thank you.